but we are going to correct these mistakes. And from Lower Egypt, or the northern part of the country, we got 860 cases, and from Upper Egypt, 85 cases. And this is a graph that shows the most important causes of chronic kidney disease that we have been able to classify. And you can see that the single most common cause for chronic kidney disease in our patient population is obstructive uropathy. And unfortunately, one of the very unfortunate findings is that the second most common reason are unknown causes. And actually, whenever we look or compare data between different countries, I think that the fact that we have such a big number of unknown causes I think there's a direct relationship or a direct proportionality between how advanced the country is and how high the percentage of unknown causes of CKD are. And of course, in developed countries, the unknown causes do not exceed 1 to 2%. And we also find a big number of cases, a big number due to reflux and UTI and aplasia and hypoplasia. If we add the congenital anomalies, the aplasia, hypoplasia, the reflux, UTI, and obstructive uropathy, they may come up to around 50% of the total causes of chronic kidney disease in children. And other causes of glomerulonephritis, of course, include lupus. And we have other causes like syndromes, Prune belly syndrome, included under other causes, Prune belly syndrome and Bardet-Biedl, and some other rare findings. Familial metabolic diseases constituted 6% of the causes of chronic kidney disease. And we have detailed statistics and graphs for each university, and we can compare each university with another, but I'm not going to bore you with the details of university findings, except to say that there may be some minor differences or some noticeable differences between the data from certain universities, because we felt that advanced pediatric nephrology centers have more referrals of, for example, hereditary disorders and congenital renal disease compared to other universities that may not offer advanced services like certain other universities. And we have, as I said, graphs showing the data from each specific university. And we, as I said, when we compare our data with data from other countries in the Middle East or from advanced or developed countries, the most striking difference and the most painful finding is the fact that we still have 16.6% compared to much lower percentages of causes that are unknown, which points to the fact that these patients are neglected for a very long time. It takes a long time to refer them to a good pediatric nephrology center that can help these children early enough before they arrive at the stage where we do not know what was the cause of their chronic kidney disease. And we can also classify the different stages according to age group. And of course, you can see that the majority of our patients were stage 5. As you can see, stage 5 patients constituted more than 50 to 60% of all the patients that we have been able to study. We also classified the patients according to the therapy that they received, and you can see that hemodialysis, of course, is almost the single type of renal replacement therapy that's being used, except for Alexandria University, which was able to provide PD services to 35 of their patients. However, I still regret to say that nowadays the chronic peritoneal dialysis service in Alexandria are also dwindling. So we have, and I'm sure you all know the causes for this difficulty with PD. Just finally, to conclude, actually a better understanding of CKD epidemiology makes a precise and early diagnosis of CKD possible. We can identify preventable or reversible causes of progression of chronic kidney disease. We can predict prognosis and aid the counseling of children and their families. It's hoped that this study would form the basis of a permanent registry for CKD cases in children in Egypt, and we need more trained pediatric nephrologists and pediatric nephrology units. I'm sure you've seen the same group with Professor Naveen. This is our group. And in a situation of limited resources, it may be more cost effective to direct resources towards preventive nephrology compared to treating patients after the disease has already progressed, and more effort and research is needed to improve the understanding of the differences in incidence between countries, causes and progression of CKD in order to prevent renal failure. I'd like to thank, first of all colleagues in the pediatric nephrology units of the 11 universities who cooperated in this joint effort, and Dr. Abdullah Bakhit, who did most of the data collection from the universities, my colleague Professor Fatina Fadel, and my colleague Dr. Rash Assam, who helped a lot with the paperwork, and our patients and families. Thank you very much.
Thank you very much, Professor Hisham. And any questions? Professor Hala?
Epidemiological study. I have just a comment about the etiology of CKD among your children. I noticed around 40% of your patients are caused by obstructive uropathy and reflux. So I guess the crosstalk between the pediatric neurosurgeon and you as a pediatric nephrologist may solve a great portion of the problem.
Thank you very much, Professor Hala. Again, this is a well-known difference between developed and developing countries, is how early we can detect these cases. Of course, if there is adequate prenatal care for mothers, many of these anomalies may be detected early enough, and the mother is informed, for example, that there is some abnormality to be followed later on. On the other hand, again, many mothers miss the detection of these anomalies, and as you see, they come in an advanced stage because they are neglected and nobody noticed, as well as the referral, by the time the urologist interferes, is frequently very late. This is true. This is the idea that we can come out with defects in research. واضح. انت بتسألني عن حاجة انت عاملها معايا ولا؟
هسأل هم just two observations that CKD stage 5 is more than 50% of cases, and this emphasizes what my professor Dr. Hisham said, that most cases of earlier CKD have not been reported and most probably have not been detected or referred to the nephrology services, because most series report that CKD 5 is much less than 50%, and sometimes the etiologies are different, because we have several conditions that are relatively common in childhood but don't cause end-stage renal disease in childhood. The other observation that hemodialysis is the mode of renal replacement in more than 90% of cases of CKD stage 5, while generally transplantation and CKD are the preferred modalities in this age group in general. So I think there are many differences between what's in our country and what's reported elsewhere, which emphasizes the need to have our own registry, as you have.
Thank you.
Dr. Rina, yes?
Subject that you are, putting for us. Did I miss the prevalence of CKD? The prevalence.
Of course. As I said, prevalence studies are extremely difficult to do, and even articles from our part of the world that give causes of CKD do not give the prevalence of CKD in this part of the world, because this needs extensive studies. That I think if we are able to do a registry, an adequate registry, in that case we will be able to. And of course we have to also include Ministry of Health hospitals. We should not forget MOH. This work was done only in university hospitals, so we need to also combine data from Ministry of Health hospitals.
Yeah, the reason why, because you will see in many of our countries and maybe outside where they know exactly the prevalence of CKD, they can conduct a preventive measures, like urine analysis in, for example, pediatric in the school. I stopped this in Syria because they were like, because we don't know the prevalence and what's what to detect and where to, draw the line to interfere or not to interfere. So are you with the, examination of urine in pediatric?
Actually, when we review articles related to the mass screening of the pediatric population, for example, by a urine analysis, it's done only in a few Asian countries. Japan is leading in the mass screening of urine for children, and it's done also in some Southeast Asian countries. However, Europe and the United States, they did not find it was cost effective enough to continue mass urinary screening. And that's why nowadays the tendency to do mass screening is declining. And it's being done only in a few countries because everything there is calculated how cost effective it is. For example, how many cases will they catch and what's the cost of doing the mass screening of this urine.
Last question, Professor Naveen.
Thank you very much, Professor Hisham, for this wonderful presentation. I admire your enthusiasm. And thanks for referring to the necessity to address the idiopathic causes of CKD. And I remember, and Fatina would probably remember as well, when we started the service, there was almost 40-something patients, right? Idiopathic. So dropping to 16 is a huge thing. 16%, though you might think. And I think we even discovered that almost 1/5 of our patients were inherited kidney diseases, so this probably brought this percentage down. And I just wanted to comment, if you would allow me, on Professor Hala's question about the obstructive uropathies. Obstructive uropathies are the commonest cause of CKD even in developed countries. So it's not a problem of yeah, we need to diagnose antenatal diagnosis, but the obstructive uropathies that are happening in the first year of life are probably more of posterior throat valve, for example, which is the nightmare of all pediatric nephrologists and urologists as well. If they start early enough to present in the first year of life, then they started in utero, yes, with a great probability that the kidneys are no more normal, even if you relieve the obstruction, yes, obstructive uropathy. So you'll have remnants of dysplastic kidneys, which won't be corrected. So this is against the notion that most people would think that if I get a posterior throat valve and early enough, then I could relieve the obstruction, everything would be just fine. If you can imagine that posterior throat valve diagnosed in the first year of life, if you relieve the obstruction, there is still a possibility that 75% of the patients would pass into end stage, and I think we see it all in our everyday practice. So I just wanted to refer to this one.
Thank you very much. Of course, obstructive uropathy is the most common cause in developed countries as well. This is definitely, and I think the unknown causes that we classify as unknown will turn out to be either neglected glomerulonephritis cases or neglected UTI cases or hereditary disorders. I do not think they will increase the urological causes. They will increase the glomerular causes, UTI causes, and hereditary nephropathies. This is the...
Yes.
We need to move on. Thank you.
Before I go, I'd like to thank Professor Megid Nahas for accepting to review this paper and to give us his comments, because his comments are very valuable for us.
Thank you. Short comment regarding the... In 1994 and to 1996, we had experience in the screening 10,000 children at primary school. And we got an important lesson. Diagnosing CKD stage 1 is very difficult, as it's difficult in adults, it's difficult in pediatrics. And when we did the first urine analysis, we found a lot of proteinuria and hematuria. And when we repeat, we didn't find the persistent proteinuria. So we should be cautious in interpreting any abnormality in urine analysis. It should be persistent as the classic definition mentioned. Thank you.
Thank you very much. We better move on. Our last speaker is Professor Mohammed Nasrallah, Associate Professor of Nephrology at Cairo University. I've known Mohammed for many, many years. He's extremely astute and experienced clinical nephrologist, considerable interest in clinical research and clinical trials, and is dedicated to educating the younger nephrologists through various channels, including his famous 4CKD workshop, which is one of the highest rated workshops by ERA, EDTA every year. So well done, and Mohammed will talk to us today about improving outcomes in myeloma kidney. Muhammad Nasrallah.
Thank you very much. Bismillah ar-Rahman ar-Rahim. Alhamdulillah Rabbil Alameen. Wa salatu wa salam ala Rasulullah. Professor Magid, thank you very much for this flattering introduction. I'd like also to thank the panel and the organizing committee for inviting me to this very elite gathering. I'd like to thank everyone in this hall for being here to listen to me. I don't want to bore you or anything, so I'll try to be fast. I'll try to be concise. I'd also specifically like to thank my dear friend Muhammad Abdi Gawad, who helped me find most of the articles that I needed for this presentation. So we'll be talking about improving outcomes in myeloma kidney. The first thing that happened to me actually when I heard this was I felt bored. I didn't know هما بيعملوا فيا كده ليه. And I thought that this was what's going to happen to people who start listening to what I was going to do, especially it was going to be at the end of the day. So I decided I'd do it this way. We'll tell a story. I'll try not to use lots of medical jargon. I'll try not to use many figures. I won't go into details, but we'll try to come out with 5 simple steps that can really help us improve the outcomes of those patients. The story started when William McIntyre in 1847 found a patient with lower limb edema. He thought that the patient might have proteinuria, so he started as a clinician to test proteinuria for the patient in a urine sample. He went to the lab, he heated the urine at temperature around 45. He found that a cloud appeared in the urine. It precipitated at 60 degrees centigrade, and then it disappeared at boiling and reappeared on cooling. He sent this urine sample to a very renowned biochemist known as Henry Benz Jones, describing the condition of the patient. And when McIntyre tried to publish this work in 1850, he found that Benz Jones has published it as a single author without taking permission. Now, that was a shock, but I really don't want to really be unfair to this man because he is a renowned biochemist, and he's not the one who called the Benz Jones proteins. And he is one of the very prominent biochemists and doctors in the history of medicine. Probably this is just one of his pitfalls. Anyways, finding out the Benz Jones proteins, discovering them, was the first ever tumor marker to be discovered in medicine. This is the first tumor that can be, multiple myeloma was the first tumor that could be diagnosed by a bioassay. By that time, of course, neither McIntyre nor Benz Jones knew that they were dealing with a tumor. They just didn't know what the disease was. Later on, in the year 1900, this nice article was published by James Wright, describing a patient with so many tumor masses and saying that this was probably the 20th case discovered, including the patients the patients reported by McIntyre and Benz Jones. And by that time, they were calling it a plasma sarcoma, a malignant lymphosarcoma by that time. And he detailed, in this case report, the patient with a very advanced multiple myeloma with lots of bone masses who died after 4 months in the hospital. He didn't receive any treatment, but they did a very detailed autopsy. And in the autopsy, he said that we should not call the tumor that was recently being called multiple, he called